Okay, next.
With the last speaker today, Dr. Abdullah Alkhodhair, very interesting topic, intervention modality for pulmonary hypertension.
So this is my agenda for the talk. So we'll just go over the overview of pulmonary hypertension. There are some new definitions in the field. Then we'll talk about some of the procedural interventions that we can do. So this is the updated definition of pulmonary hypertension released just a couple of months ago. The change is that mean PA pressure is now defined as more than 20 as opposed to 25, and PVR is less than 2 as opposed to 3 in the past. Now, the problem with this definition is most of our treatment trials use the previous definition, so we have now people that have the disease, but we don't know yet if the treatment is beneficial or not. Very important to define the etiology of pulmonary hypertension, and we do that by right heart catheterization. So a wedge of 15 or below or above will define you what's the most likely etiology of pulmonary hypertension. Now, those are the 5 clinical groups of pulmonary hypertension. We're interested in group 1, the pulmonary arterial hypertension. Most of our treatments work in this group. And also group 4, they share the same pathophysiology somewhat, and our treatment can work there. Group 2, which is mostly due to left heart disease, has been a topic for lots of research trying to find if pulmonary hypertension medication will work, but unfortunately, none of the trials that looked at this group have been successful when it comes to pulmonary hypertension at least. Those are the 3 treatment pathways that we're focusing. The main pathophysiology of pulmonary hypertension is an imbalance between vasoconstrictors, vasodilators. So we have the endothelin pathway, we have the nitric oxide pathway, and we have the prostacyclin pathways. Now, when I started preparing for this topic, I thought I'm bringing something new, but I realized that people since the 1960s have been thinking about this. So this article here discusses the surgical treatment of primary pulmonary hypertension, as it was called back in the days. So why do we use catheter-based interventions? Number 1, because pulmonary hypertension is a progressive disease and it's not curative except by lung transplant, which has its own problems. The second issue is that the PAH medications are expensive, they have side effects, and they're not always available, especially in third world countries. And finally, not all patients who are treated respond to medical therapy, so we have to explore other options. So the first strategy entails creating right to left shunting, or in a way you can call it venting of the RV. And it comes from the observation that Eisenmenger patients have better outcomes compared to their counterparts who have just PAH. So because of this communication between the right and the left, you can decompress the RV. This will then increase the systemic blood flow through increasing the LV preload. You will have some decrease in oxygen saturation, but probably the net benefit the net benefit of increasing cardiac output probably outweighs the risk of having this small decrease in oxygen saturation. We don't have great evidence to support this, but it's mostly from case series and case reports, and it is still a palliative procedure. So first, or the most well-known procedure is atrial septostomy. So we use a standard transseptal approach. Here you have a pigtail in the aorta, you cross, then you just do a serial balloon dilatation. You put your pigtail in the LV to measure the EDP with each balloon dilatation. And basically what you want to look at is not more than elevation of not more than 20 in the EDP and drop of not more than 10 points in the oxygen saturation. It has to be done under TE because sometimes the RA is so huge and there is a risk of perforating when you do the transseptal puncture. So basically the procedure aim is to increase the cardiac output. This will improve your NYHA class and decrease the risk of syncope. This procedure, when it started, had an unacceptable risk of mortality, probably because of the severe hypoxemia. So that's why we now recommend stopping when there is certain criteria, measuring the oxygen and also the pressures in the ventricle. Patient selection is important, like anything else we do. Should not be offered to patients who have baseline hypoxemia or severe RV failure or low cardiac output, or high RI pressure. Now, the problem with these devices, or with atrial septostomy, is most of the time there is spontaneous closure of the perforation that we've created. So that's why we now have multiple devices. Probably most common one used is the Alkhodhair atrial flow regulator that basically allow you to have a pre-selected size of the hole and prevent, of course, the closure. So the choice of the size depend on your hemodynamics and also your baseline saturation. Next, we'll talk about pod shunt. So basically, this is mostly a surgical procedure, but now there have been some cases where it has been done percutaneously. The advantage of this procedure is it allows the shunting at the lower limbs only, thereby sparing the upper limbs and the coronaries from the effect of hypoxemia. Basically, you're trying to create a communication between the left pulmonary artery and the descending aorta. It can be done percutaneously, like in this case. So it is similar somewhat to a PDA closure, but instead of closing, we're now creating an opening. So basically, you use RF, radio frequency ablation, to perforate into the PA and then snare the wire, and then just the rest is self-explanatory. You can do a covered stent to prevent any leak in between. Again, very high-risk procedure, should be done only in centers where there is experience in this type of procedures, not commonly done. Now, the hot topic is something called pulmonary artery denervation, or PADN. So basically, the idea is that like in heart failure, pulmonary artery hypertension has a overstimulation of sympathetic nervous system. The pulmonary arteries are densely innervated by sympathetic nerve fibers and baroreceptors near the bifurcation. And the idea was derived actually from renal artery denervation. So what do we do here? So this is a catheter that was invented in China, and most of our knowledge about this procedure comes from China. So basically, the catheter had a circular tip with 10 pre-mounted electrodes. So basically, you put in a sheath into or near the bifurcation, and you advance your catheter, and then you do 3 or 4 ablations, 1 minute each, on different sides around the bifurcation. And with each time, you can expect to have some chest pain. And the procedural success was defined in their trial as reduction in mean PA pressure of more than 10 millimeter mercury. I started with this trial back in 2013. The results were so good to be believed as true results. There was some concerns about the conduction of the studies until this year, when we had a randomized controlled sham trial. So basically, they took patients newly diagnosed PAH. They randomized them into, they gave both groups sildenafil or tadalafil, and then they randomized them into sham versus PADN procedure. And what you can see at the bottom here, the group who received PADN had better 6-minute walk test, less or more increase or more reduction in the biomarkers level, and more reduction in PVR. And also, as a secondary endpoint, less worsening of their disease compared to the other group. So very promising results, and I think we will see more and more of denervation in the pulmonary hypertension arena in the future. Another device that has been used, again, different devices that can be used for denervation. Some people have also tried just the same methodology they use in AFib ablation. Still, the area is open to new innovation and more trials. Finally, we'll finish with something called balloon pulmonary angioplasty in patients with CTEPH. Remember, CTEPH is chronic thromboembolic pulmonary hypertension, group 4. So basically, the pathology here is incomplete resolution of the clot, and the clot then will organize into fibrous tissue. The non-obstructed vessels will undergo some remodeling, and if you take biopsy, it will be similar to what you see in group 1. The treatment of choice is pulmonary endarterectomy, but not all patients are candidate for this procedure. Sometimes the obstruction is so distal that the surgeons cannot access it. And a lot of patients, they have comorbidities that prevent them from undergoing this major surgery. In addition, some patients will have the surgery but have some residual disease as well. So BPA started in the 2000s. The Japanese group have refined and improved the procedure in the early 2010s, and now they have the biggest publications to demonstrate the importance of this procedure, the good hemodynamic results, and the low complication rates as just like a reflection of the learning curve they have gone through. So basically, the choice of treatment strategy depends on where is the obstruction. So if the obstruction is proximal, then surgery is probably the better choice. If the obstruction is in the mid-range, then there is a room for balloon pulmonary angioplasty. If it's too distal, then probably even the balloon will not reach, and medications remain the only choice. So this is just an example of one of the procedures. So basically, they use tools similar to what we use in coronaries, except they don't use stents. So they can use, there are different lesions. There are web lesions, CTOs. Some people have used IVUS or like physiology testing to assess the significance of lesions. And basically, you have to do multiple sessions. You have to target different areas and different sessions. You're trying to reduce the risk of reperfusion lung edema. And that's why sometimes you need to do multiple 4 or 5 or 6 different sessions spared between, like in a span of a month or two, to reach your final results. So it is, again, a multidisciplinary team approach, and you know your target vessel depending on your perfusion scans, and this is where you should go and target your intervention. So with that, I conclude in my time, and I thank you very much. Happy to answer any questions.
Excellent presentation, Abdullah. Do we have any questions? Yes, please.
First, congratulations for defeating the challenge of time. And secondly, do you have any tips and tricks for manipulating and maneuvering the wires and balloons and instruments through the pulmonary circulation, despite that the branching is extremely complex in 3D anatomies and not in kind of reproducible or well-standardized known anatomy like the coronary bifurcations? So anyone can go looking at the cine images in 2D frames and he can get lost very easily. So what do you advise anybody starting to dream of this procedure?
Yeah, good question. I think there is, as has been shown in the Japanese registry, there is a steep learning curve. So when they started, they had a lot of complications. So I suggest that if you're starting this program, it has to be done carefully. It has to be done with proctorship. The operator has to see like multiple interventions before they start doing them. They suggest using just the regular wires, no stiff wires. Of course, you're going to use similar guides to what we use in the coronaries. Some people go transjugular, some people go femoral. There's lots of tips and tricks, and it also depends on the type of lesion. There are easy lesions to fix, and then there are the CTOs and the web lesions and the more difficult ones. So, I mean, as a beginner, you should probably just go and target the easy lesions that just require pre-dilatation without like specialty wires and microcatheter, etc. And then experience will be built that way.
Sure. Thank you. Yes. Yeah. Yes, please.
Abdullah, great talk. I enjoyed it a lot. My question, why not stenting? I mean, if you're going to do angioplasty to those vessels, what's against stenting?
Good question. So if you look at the, you know, we do stenting for atherosclerosis, which is embedded within the wall. So there's a great chance of recoil if you just do a balloon angioplasty for an atherosclerotic lesion. But here the pathology is different. Here you have an organized thrombus just outside the architecture of the wall. So by doing balloon dilatation, you're probably just going to push that to the wall. There is no, the wall itself will not be recoiled on you, and that's why stenting has not been. And the other thing is, you know, you do up to like 10, 20 lesions in total when you do this procedure. So I'm happy. I know that the companies will be happy if we're stenting this, but I don't think it's the right thing to do. You know, risk of stent thrombosis.
I mean, because I know, and you mentioned that actually those lesions transfer into fibrotic tissue, which is actually not very easy to just get rid of with ballooning alone.
Yeah, but the results that have been shown with balloon angioplasty alone has been satisfactory. Even when they bring the patients like 1 or 2 years after for pulmonary angiogram, you still have patency of the vessels. So, I mean, you avoid all of the risk and complications with stenting. But, I mean, of course, if you have perforation, things like that, then I think covered stent would be something reasonable to do, but not as a strategy.
Great, thank you very much.
One last question. So with the new interventions for PEs coming, lots of interventions now in the PE realm for the PE, do you think CTIF will be more of a problem or less of a problem because we are dislodging a lot of clots?
Yeah, very good question. So far, we have a lot of new interventions targeting acute PE, and there has not yet been any evidence to support that if you have a massive PE or if you use any of these suction device, that your CTEPH incidence is going to be reduced. You know, we know that after a PE, the risk of CTEPH is between 2 to 5%, depending on the studies you look at. So far, we don't have any evidence to suggest that these devices will reduce the risk of CTEPH in the future. But we know with COVID, there was a lot of PEs, and it is expected that the CTEPH incidence will increase in the next couple of years just because of the sequelae of COVID pandemics.
Abdullah, thank you very much for this great talk. And we have reached the end of this session. I would like to thank the speakers, Dr. Faisal, Dr. Sundus, and Abdullah for these excellent talks in this area. And also, I would like to thank the expert panelists, Ahmed, Mohammed, and Wael. And overall, I would like to thank you all for your attention. Thank you, and enjoy the rest of the meeting. Thank you.